Hi everybody! Okay, so today I wanted to talk about SIADH and diabetes insipidus. I just wanted to touch on the things that I'm learning at my particular school. This is focused towards our first test coming up. But I just wanted to talk about it. It helps me to learn, and I hope it helps all of you to learn as well. So SIADH and diabetes insipidus has to deal with the kidneys and anti-diuretic hormone. So for the purposes of learning this concept for nursing school, I think it's very helpful if you take ADH as a term in and of itself, anti-diuretic hormone, and you cross it out and you replace it with fluid retention. I think SIADH and DI get very confusing because you have the words increased, decreased, and you have anti-diuretic. It all gets very shuffled and confusing. So I think if you take ADH, put it in your mind that that's what's involved, but think of it more so in terms of ADH equals fluid retention. So moving forward, let's start with SIADH, which is syndrome of inappropriate anti-diuretic hormone. So inappropriate fluid retention, which means your fluid retention is increased. You are holding on to fluid. So let's start by talking about signs and symptoms of this. Change in level of consciousness, headache, seizures, delusional hyponatremia, which I'm going to talk about in a second, weight gain, and decreased urine output because you are retaining fluid, you are holding on to it. So definitely eyes and O's and daily weights are going to be a part of management and nursing care involved with a patient suffering from SIADH. What are other things that are going to happen when a patient is experiencing SIADH? Well, first, the serum sodium will be diluted. And I think sodium we know is very important to the body, but I think talking about in terms of normal versus abnormal is very beneficial. So let's take this little guy here and pretend he is our normal cell. He's in equilibrium. We have 4 salts, 4 sodium, 4 water. Equal, balanced, life is good. Now let me start off by saying that this 4-to-4 ratio is only going to be used for this learning example. There's no 4-to-4 ratio that exists in your cells, but I think it's helpful. So normal cell, chilling out, 4 sodiums to 4 water. He's happy. So what happens to this cell in SIADH? Well, we have, as I said before, delusional hyponatremia. So the sodium level appears to be lower than normal. Well, it's not so much that there's an actual decrease in sodium. It's just that there is so much more water because of that fluid retention. So now we have a cell that is so swollen with water. We're going to come back to this in a minute, but just keep this in mind. This is what's happening with the sodium. It's not necessarily a loss of sodium. It's just so much retention of fluid that the sodium appears to be lower. There's less of it. It's not in a 4-to-4 ratio. This is an 8-to-4 ratio now. 8 water, 4 sodium. So delusional hyponatremia is something that's going to show up as evidence that SIADH is occurring. The serum osmolality will be decreased. So that is your blood, your vascular concentration. It's going to be decreased because there's so much more fluid. So there's more fluid than solutes. You're going to have a decreased serum osmolality. Your urine output, we already touched on, is going to be decreased. You're holding on to water. And we all know that decreased urine output leads to concentration of fluid within the bladder, which means that your urine osmolality, your urine concentration, is going to be super high. It's going to be increased. How do we treat it? So let's go back to what's happening in this cell, this SIADH cell. First off, we want to restrict fluids. There's already more than enough fluid in this cell. So we want to restrict it. I have, my school's teaching that 800 to 1,000 milliliter per day fluid restriction. And that's an effort to attempt to correct the sodium. If a couple of these water droplets leave, we'll hopefully get closer and closer to this equilibrium state that the cell is dying to be in. We know the body will do everything it can to get back to equilibrium. So fluid restriction, and on top of that, we're going to give hypertonic IV fluids. So you might think, why would we give more fluids? The patient might ask, why would we give more fluids? I'm already in fluid retention. Well, we're giving more fluids. We're giving hypertonic fluids because hypertonic fluids shrink cells. Now, which fluids are hypertonic? Well, those are your normal salines above 0.09 normal saline. So your 3% normal saline, your 5% normal saline, those are hypertonic IV solutions. And they're gonna help, just like the fluid restriction, to draw these water droplets out, to get rid of that dilutional hypernatremia and get our cell back to the state that it wants to be in. So I hope that sums it up a little bit. It's gonna create a fluid shift between the fluid restriction and the hypertonic saline. You're gonna cause a fluid shift so the cells go from looking like this, they're fat, they're swollen, they want to go back to this, and that's what we as nurses want to get them back to. So that's SIADH. Remember, increased ADH, increased fluid retention. Let's move on to diabetes insipidus. Now, we know these are opposites. Diabetes insipidus is inadequate secretion of anti-diuretic hormone. So replace that ADH with fluid retention. It's inadequate fluid retention. So the body is just letting go of water left and right. It's not hanging on to anything. Losing all of that fluid can lead to dehydration. So what is the patient going to present with? Signs and symptoms. Extreme thirst. If you're peeing out all of the fluid in your body, you're going to be thirsty. Again, your body wants to compensate, so it's going to be asking for more fluid. Excessive urine output, we just said, you're constantly peeing, so their output's gonna be high. Generalized weakness, if you're dehydrated, you're going to be weak, you're gonna have lethargy. And then on top of that, you're gonna have hypotension because not enough fluid to circulate and to perfuse. And we know a compensatory mechanism of hypotension is tachycardia. So this patient might present thirsty, peeing a ton, their BP is gonna be low, their heart rate's gonna be high, and they're gonna be weak. So what's actually going on in the body? We know the kidneys are secreting water left and right, but what else is happening? So in our normal cell, in our 4:4 ratio, now we have increased sodium level. So before, in SIADH, we had dilutional hyponatremia. Now we're gonna have hypernatremia. Why? They're peeing out all the water. This little cell is so shrunk. So we went from having 4:4 to only having 2:4 because the water's almost all gone. So our cells are looking a lot more salty. So hypernatremia. The serum osmolality will also be increased because you're letting go of all that fluid. So the other solutes left in your vascular system are going to be left alone. So that concentration is going to go up. We already said your urine output is increased. And just like we said, when your urine output is decreasing, you're holding on, you have increased urine osmolality. When you are letting go of urine in DI, you will have decreased urine osmolality. Your urine is going to be much less concentrated. So how do we go about treating this? Now again, this is our cell, our little shrunken cell. It's totally dehydrated and it wants to go back to this. So how do we as nurses get it back to this nice equilibrium? Well, first we want to increase fluids. So in SIADH, we wanted to restrict fluids. Now we want to increase fluids because we're missing fluids. We're missing 2 fluids. We want to give more. So we're going to encourage PO fluid intake. And we're also going to put them on an IV, but this time it's going to be hypotonic. So how I remember hypo versus hypertonic, I just kind of think of hypo as like blasting, like hypo, the cells are bursting. Now in this case, because they have so much fluid, now in this case we don't want the cells to burst, but we want them to swell because this little tiny shrunken cell wants to look like this again. So we're going to give hypotonic solutions. What IV solutions are hypotonic? Hypo, lower than 0.9 normal saline. So we know 0.9 is the standard. Anything lower, 0.45, 0.225, 0.33, your half normal saline, your quarter normal saline, those are your hypotonic solutions. We're going to give them so that this cell will swell and it'll become hydrated again, and that'll correct the diabetes insipidus. Another medication that we could give is vasopressin or desmopressin, which is basically just giving ADH, giving anti-diuretic hormone. And that will help to retain fluid, which will help to correct the thirst, which will help to correct the excessive urine output, and of course will correct the more fluid will help to correct the hypotension and the tachycardia. So I hope that summed it up. I hope my happy little cell with all of its salts and water helps to explain what's going on in the body during these two conditions. So again, SIADH is increased ADH, so you're retaining fluid, and then you have diabetes insipidus, which is decreased ADH. You are decreased fluid retention, you're letting everything go, and signs and symptoms will follow accordingly. Thanks so much for watching, and I hope you tune in again next time.